السلام عليكم.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
الحمد لله.
الحمد لله. Okay. Can you ask for control?
Okay. Requested.
Okay. This patient, elderly patient, presented with scrotal swelling.
Okay, so I'm presented with ultrasound of the post-disease of elderly patient presented with scrotal swelling. I'm scrolling through the images before giving my comment. Um, so the appears to be the left disease appears homogeneous with surrounding increased vascularity. I'm suspecting infectious process like epididymoorchitis that causes this increased vascularity.
Good.
Um, Comparing it to the other side.
Good.
Um,
It's good
However, I
this
could
case
see.
came to a female radiologist. I'm happy now. Okay.
However, I could suspect here a dilated inguinal canal on the left side was
Mm,
not sure.
okay. Okay. You saw all images. So your final diagnosis?
So I'm suspecting left epididymoorchitis with edematous subcutaneous tissue
Good.
and
And the
increased
patient will
vascularity.
take antibiotic and die at home safely. Okay. Okay. Look at yes, this image. What are these
Yeah,
echogenic foci, my friend?
so it could be gas foci.
Yes,
So
definitely gas.
yeah,
Definitely gas.
for
You
near
see?
gangrene.
Yes,
Yeah,
for near gangrene. You see? Multiple
yes.
echogenic foci, some of it linear, it's irregular, scattered along the soft
Mm,
tissues and along the
yes.
inguinal region. And you see here,
Hmm.
it's obscuring part of the image. You see?
Okay.
This is
Yeah.
very, very dangerous. By the way, away from the exam, many radiology residents miss this case, not just you. I
Mm,
said I'm happy because you are a female radiologist because female radiologists don't do scrotal ultrasound. So it will be very hard case in the exam. So please, my friends, revise epididymoorchitis, testicular torsion, testicular rupture, and foraneer gangrene. Okay,
okay.
very important and crucial. يعني urgent surgery will be needed. Okay, so I know we have some epididymitis, but we have air, extensive air. You see, extensive air. What is the next imaging modality?
CT.
Yes, yes. No answers, please, in the chat box. Please, you can answer in the Facebook freely, but in the chat, in the Zoom, no answers, please. Okay. What do you see here?
This is a scout view of the pelvis. Um,
Hmm?
there's abnormal radio dense shadow
No,
extending
you
below.
ignore the density. Okay. It's summation of
Okay.
shadows. Any
Yeah.
lucences, any abnormal lucences,
Maybe yes, below the pubic rami, there's linear lucent areas maybe suspected for gas.
where
Below the left
yes, you
inferior
see
pubic
this
ramus.
area. You see all
Yes.
this area. This patient have extensive, massive scrotal edema, and you see gas along the left side of scrotal sac and along the left side of the perineum. Let's and now from CT scan, you see it's extensive gas along the inguinal canal, along the inguinal region, along the perineum. Okay, in this non-contrast study, and it's urosurgical emergency. This is a foraneer gangrene.
Yeah.
Okay, good, my friend, and forgive me. I'll give you another case, but this time easy. Okay,
Okay.
related
Thank
to
you.
female radiologist. This patient post-operative, postpartum renal or loin pain. What do you see?
Okay, so I'm presented with ultrasound of patient postpartum with right loin pain. I scroll through my images before giving my comment. This is ultrasound of the renal region, which appears to be enlarged with hyperechoic areas scattered through the renal parenchyma.
Good. So it's enlarged and echogenic affected kidney on the affected side of the pain. I know ultrasound doesn't give us more information in these images, but what do you think? What happened? Postpartum, loin pain, echogenic kidney, enlarged?
Maybe infected.
So I will correlate with patient history about fever, for example. Okay,
Yes.
no fever, and leukocytic count is not high. Any other possibility?
Could be injury postpartum.
Good, but usually bilateral.
Yes.
Acute renal injury, yes, especially if retained products of conception. Good possibility. Good. What else?
Could be infarction, like ischemic injury of the kidney.
Okay, let's. What you will do next?
CT with contrast.
Yes, proceed. Because
So
this is an important case for practice also.
Okay, so I'm presented with CT of the abdomen post contrast. I will go through the images before I give my comment. So the
Sorry,
left
it was
kidney
the left kidney, not the right. Okay.
Yeah, so the left kidney appears to be hyper-enhancing in comparison to the right side.
Good.
However, no dilatation of the pelvic calyceal system. I will go through the last cut. Okay, so the most striking abnormality is in the left kidney with hypoenhancement, considering them as a patient in the postpartum and gone through some surgery. So I'm suspecting injury to the renal artery.
Why renal artery? Why? It's a retroperitoneal structure and very high. It's away from pelvic surgery or uterine surgery.
Yeah,
More common.
renal
Something
vein.
more common. Any pregnant lady can be exposed to 1 to 3. Any postpartum can be exposed to 1 to 3.
So venous thrombophlebitis, maybe?
Show me the renal vein. Good. Show me the renal vein.
I think here.
Renal vein.
Not gonadal, yeah.
Yes, it's gonadal, but okay, I want to see the renal vein itself. It will be
It's
very,
here.
very, yes.
Yeah.
Go up, go.
Okay.
Yes.
Yeah.
Do you see any thrombus in the left renal vein?
Yeah, it's hyperdense here within the renal vein.
No. Let me get have the control. Let me have the control. Okay.
Yeah.
So it's a very important pregnancy and postpartum hypercoagulable condition. You see the aorta, this abdominal aorta, and this superior mesenteric artery. What is this structure?
Left renal vein.
Yes, you see in the its entrance into the IVC, this patent, but filling defect. It's expanded with the smudging of the fat planes, enhancing vasa vasorum, but the internal lumen is completely thrombosed. Completely thrombosed. So whenever you see enlarged kidney, hypo-enhancing, okay, enlarged kidney, and the hypo, it was my question, okay. Okay, hypo enhancing, enlarged kidney with a smudging of the fat planes. Think of 3 common etiologies. Okay,
Yes.
Either obstruction by stone, yes, it can cause this appearance. It's a delayed or striated nephrogram, or infection, acute pyelonephritis. I want to correlate with the inflammatory markers, or in such history, renal vein thrombosis. And very good, you detected the difficult one. You detected gonadal vein thrombosis and missed the renal vein. This is a difficult one, by the way. It's common. The thrombosis started as thrombophlebitis of the gonadal veins, either the right, which is more dangerous because it ascends directly to the IVC, or the left gonadal vein. The left gonadal veins can be many. It has many trunks, and it drains into the left renal vein. So it's a case of left renal and left gonadal also thrombosis. This is a cause of abnormal nephrogram. And we enlisted the other causes like infection or obstruction. But in this setting, thrombosis. Okay. Okay, my friend. The last question, management.
So this is emergency. I will refer the case
Yes.
to urology team for anticoagulants, maybe.
Yes.
Um,
Yes, very good, very
uh,
good. Remember, even my friends, if you missed some findings, you will take marks about the management, about the safety points, okay, about the communication skills. No problem to miss one case in each exam. No problem. Okay, don't lose your concentration. It's okay, I didn't reach the diagnosis or the main finding, okay, but I will manage the case correctly, and I will mention the safety points. In post-operative, this is second case postpartum in today's session. I'm looking for any complications like perforated uterus, perforated bladder. I will see any collections. I will see any filling defect, any mass here in smudging fat planes like bladder flap hematoma, bladder flap, infected bladder flap hematoma or abscess, endometritis, any area of abnormal vascularity, as in case of AVM, for example, with dilated vessels, any smudging fat planes along the psoas bilaterally. It's very important. Okay, any filling defect in the gonadal veins, and of course, renal complications. Any hypo enhancement, unilateral or bilateral. Bilateral, we can suspect acute renal injury. Unilateral, renal vein thrombosis or infection, and so on. Thank you, my friend. Thank you.
thank you,
Well
sir.
done. Okay, the next friend.
Yes, sir.
Okay, can you ask for control?
Sure, sir. Yes, sir. Requested, sir.
Okay. This is an easy case, my friend. Okay, the patient has loin pain followed by shock.
Okay, sir. Sir, I am provided with axial non-contrast images of abdomen. In my usual practice, I usually scroll the images first. Sir, I can appreciate there is a mild left-sided pleural effusion
And
uh, and basal atelectasis. On
and
scrolling to the
okay.
on scrolling to the abdominal section, uh, I can appreciate there's a large uh, abnormal area in left flank region. On scrolling to the pelvic images, I cannot appreciate any abnormality.
Last cut, last cut. Remember, every one of you, even the last cut here is normal. But remember, don't forget the last 2 or 3 cuts. Very important in the exam setting. Even it is normal, you will take marks if you reach the last cut, and you will lose if you didn't reach the last cuts. It's very important. Okay, my
Right.
friend, you can continue.
Okay, on scrolling back to the abdominal region. Sir, could you tell me what is the history, sir?
Loin pain, then shock.
Okay, sir. Sir,
Regarding the retroperitoneal abnormality, can you describe it more?
sir, I can appreciate this large mass-like area
Where?
in
Where? Show me. Use the pointer. Where?
sir, this abnormal area is
Where is the left kidney?
sir, I cannot appreciate the right or left kidney.
No, no, the
So
right kidney, I think present. Go up. The right kidney is okay. I think go up كده. Let's see the right kidney.
okay, okay, sir, okay, sir.
Where? Just okay, okay. I will. Any problem with the mouse?
Yes, sir, I think there's a bit lag in the
No
mouse.
problem, no problem. Yes, the right kidney is present here. Okay, you see it in this cut? My friend,
Yes,
you see it? Yes,
sir,
the right kidney is here.
yes,
Where is the left
yes.
kidney? In the same cut. Yes,
Sir,
yes, yes. Yes, is one.
okay, sir. I think,
Okay.
sir, this is a
Mhm.
large. There's a large mass. It's replacing the right kidney,
Good. What
and
about the density of this area?
sir, this is isodense, iso to hypodense to the
Yes.
renal parenchyma.
Concentrate, my friend, on this area. You see the mouse now? The area
Sir,
surrounding the kidney is hyperdense. Yes, the area surrounding
okay,
the
sir.
kidney is hyperdense, and the area involving the psoas also is relatively hyperdense as compared,
Right, sir.
yes, as compared to the parenchyma. What comes to your mind? What happened?
Sir, if is there any history of trauma, sir? Is there any history of trauma, sir?
Very good, very good. It may be traumatic perinephric hematoma. No history of trauma. Very good
Okay,
possibility. Good. What else?
okay, sir. It could be retroperitoneal mass, likely could be lymphomatous mass, sir. It could be.
Lymphoma. Yes,
Yes.
lymphoma, one of the pattern, it may be perinephric, but lymphoma is hyperdense.
Sir, lymphoma is actually isodense. It's an
Yes,
isodense mass.
it's difficult to be differentiated from the renal parenchyma in the pre-contrast. This is a hyperdense structure with the smudging of the fat brains, displacing the
Uh,
kidney. It's a
sir,
hematoma, my
actually,
friend. It's a hematoma.
oh,
Okay.
okay, sir.
So, what is your differential? What happened if no history of trauma?
Sir, there could be possibility of ruptured AML, sir.
Excellent. Yes, avoid abbreviations in the exam. Excellent. Maybe ruptured angiomyolipoma. Do you see any fat-containing lesion?
Yes, sir, I can appreciate this fat containing areas.
Where actually this is a perinephric fat. This is a perinephric fat.
Sir,
But good possibility, my friend. Good possibility. No, no. It should be
oh,
within the center of the hemorrhage. It should be exophatic here. The fat-containing lesion should be exophatic from the renal parenchyma, which is not. So ruptured angiomyolipoma is a good possibility. Anything else?
sir, sir, it could be it could be renal cell carcinoma, sir. It could be
Very good.
renal cell
Yes.
carcinoma.
Yes, ruptured renal neoplasm like renal cell carcinoma. If a cystic
Sir,
ruptured renal cyst, hemorrhagic cyst or else, it may be ruptured hydatid. Very good, my friend. Very good.
okay, sir.
What you will do next?
Sir, I would like to see post-contrast images, sir.
Very good. And also important point here. No
Okay.
stones down. Why I said no stones? Is it important in this case?
Yes, sir, because like in cases of granulonephritis, sir,
And also
there could
the stone can cause hydronephrosis, hydrocalyx, ruptured calyx also. This is another
right, sir,
possibility, my friend. Very good. So
right,
I'll
sir.
give you now, let's see this phase first. Can you comment on what happened?
Sir, now I'm provided with sir. Sir, can you scroll for me, sir?
Okay, I will. Okay. Phase. What is the phase first?
Sir, it's actually portovenous phase, sir.
Yes.
I can appreciate there is in I can appreciate the left renal parenchyma with large hypodense area, non-enhancing hypodense area in its surrounding. Uh, uh, there is anterior
Mhm.
displacement of renal parenchyma.
Good.
I cannot appreciate the left psoas muscle
Huge,
separately.
yes, huge hematoma involving the
Ye-
retroperitoneum and psoas, and also
Yes, sir.
perinephric area. What is this?
Sir, it could be a psoas abscess, sir.
What about the
Yes,
hyperdensity?
sir, sir, it's blood, sir.
Yes, it's active extravasation. It follows the signal
Yes,
of
sir.
the aorta. Active
Yes, sir.
extravasation, what does it mean? There is some
So,
vascular related
pedicle
problem.
injury, sir. Yes, sir.
Hmm?
Yes, sir. Yes, sir.
So what you will do next, in my routine practice, I'll ask for the arterial phase. For example,
Yes,
I
sir.
want to see where this come from. For example, this is the arterial phase. Before the extravasation, what happened here?
Sir,
Hmm.
sir, I cannot appreciate the left kidney. So, sir, left
Left renal artery.
renal artery. Yes, sir.
Yes, I'll give you a better image. Yes, you see here, what happened in the
Yes,
left
sir.
renal artery?
Sir, I can appreciate this focal disruption of left renal artery
Focal
with
dilatation. Focal
dilatation. Yes,
dilatation,
sir.
not
Focal
dissection.
dilatation
Okay.
of, yes, sir.
Yes,
Focal
very good.
dilatation of,
And
uh,
extravasation from this dilated segment. So what is
yes,
your
sir.
diagnosis?
Sir, aneurysm, sir. Aneurysm
Yes.
disruption from
Yes, very good.
left
Ruptured
renal.
aortic renal aneurysm. This is ruptured renal aneurysm. Okay. It can occur spontaneous. It can occur post trauma, post biopsy, for example. It may be intrarenal, as in case of polyarteritis nodosa, for example. Fibromuscular dysplasia can be associated with such condition. Management.
Sir, this is a surgical and interventional
Yes.
vascular emergency. So I would communicate my findings to the uh, vascular and surgical team for
Intervention radiology team can also help the urology team in such condition. Okay, my
yes, sir.
friend. So just to revise, perinephric collection. Perinephric
Yes, sir.
collection. Just to comment, you see, my friends, the pointer, there is hyperdensity. Hyperdensity. It's well differentiated from the non-enhanced renal parenchyma. And this hyperdensity surrounding the kidney, involving the psoas. In old age, it's very, very, very important to comment on the abdominal aorta. It may be ruptured aortic aneurysm, but here the abdominal aorta is intact and away from this hematoma. So it may be ruptured renal artery, mainly renal artery, or intrarenal arteries. It may represent a ruptured calyx in such condition. I want to see the delayed phase. It may be ruptured renal cell carcinoma, but I didn't see any enhancing mass. Maybe ruptured angiomyolipoma. This is very common. I don't see fat-containing lesion arising from the parenchyma. This fat around is a perinephric fat, is a smudging fat. It's not fatty lesion. Okay? Very good, my friend. Very good.
Thank you, sir.
Okay, the next candidate.
السلام عليكم ورحمة الله.
عليكم السلام ورحمة الله وبركاته. How are you, boss?
الحمد لله الحمد لله لعل حضرتك بخير.
Okay, this is the renal outline, my friends. Of course, it's not sharply demarcated because the fluid and the hemorrhage. Okay, if a hyperdensity around, I will suspect a hematoma, like this case. If hypodensity or cannot be differentiated from the renal parenchyma, it may be renoma. Okay. Okay, my friend, starting with easy case, then another case. يلا. You are the last candidate, correct, يا boss?
Okay.
Correct?
أيوه لحظة.
You are number 6, okay?
Number
Yes, sir.
7.
Hit the last one. Yes.
Yes, 7, number
Mhm.
7. Yes, yes. Thank you, Dr. Nagab. Okay, I'll give you 2 cases to close this list. The first one, ask for control.
I'm asking for the mouse. If I can. I can.
Okay, okay. I'll give you the mouse. You are Dr. Candidate 7.
Candidate
Okay.
7 up.
Yes, yes. I'll give you the mouse. Yes. You have the control now. Can you move the mouse? Yes. Good.
Yes. Thank
Scroll,
you.
scroll.
I'm presented with axial CT cuts of the abdomen
In
at
a patient
the
with
non-enhanced.
abdominal pain and swelling.
Okay. Non-enhanced study with the abdomen and pelvis.
Are you sure about non-enhancing?
Delayed phase.
Yes.
A delayed phase. I can see hypodense lesion at the right hepatic loop and another slightly hypodense lesion related to the gallbladder fossa. Another hypodense lesion can be identified at the left hepatic loop. Scrolling down, I can see multiple large
Mhm.
mixed lesions involving both kidneys, both retroperitoneal region. I can't identify both kidneys. Well,
Good.
scrolling down, reaching the pelvis, can see minimal fluid collection at the pelvis.
Good. By the way, my friends, this may be oral or long case. It's good for long case also. And our friend here will tell us about the detailed management, inshallah.
Okay.
Okay يا boss.
الله المستعان.
الله المستعان.
Finally, I'm suspecting
away
malignant.
from the description. Away from the description. Do you know the diagnosis?
No.
Widdy. Do you know the diagnosis?
No, I don't know the diagnosis.
No problem. So step by step, go down to this area. You see the right side of the abdomen. You see contrast extravasation.
Yes.
In the center. Yes.
I can see contrast extravasation here.
And I don't see both kidneys because replaced by fat-containing lesions. What is the disease in which the kidney replaced by fat-containing lesions?
The ansogranulomatous transformation of the kidney.
Good. Do you see any hydronephrosis or any collections? I don't see any collections.
I can't identify.
What other condition that's associated with fat-containing lesions?
Renal cell carcinoma could be containing fat. Yes.
Very rare. I know, but very rare. Angiomyolipoma, my friend. Angiomyolipoma.
And angiomyolipomas can contain fat.
Definitely, the commonest fat-containing lesion and also fat-containing lesion in the liver. This is angiomyolipoma in the liver, and this is unchanged hepatic hypodense lesion from previous studies. Okay, it may be atypical hemangioma, for example, but this hypodensity in the liver is a lipoma or more common angiomyolipoma. Bilateral kidneys, angiomyolipoma. One of these angiomyolipoma showed extravasation. What happened here?
Wunderlich syndrome.
Yes, bleeding.
Rupture
Yes.
Rupture angiomyolipoma.
What is the disease in which multiple bilateral angiomyolipoma?
Tuberous sclerosis.
Tuberous sclerosis. Can you explain this subcutaneous line? Up, down, intraperitoneal.
Shunting.
Excellent. It's a shunted tube. Good.
For treatment of hydrocephalus.
Excellent. Why hydrocephalus occurred in this patient?
Posterior fossa lesion.
No. Foramen of Monroe lesion. Foramen of Monroe lesion. What is the lesion? Siga. You need to revise, my friend. No. You need to revise. Okay.
Yes.
You have time. Okay. So I tell you, we have here the both kidneys nearly replaced by multiple fat-containing lesions enlarging the renal fossa. On the right side, we have active extravasation and massive expansion. It denotes bleeding angiomyolipoma. Bilateral angiomyolipoma, and this one represent, of course, emergency for interventional radiology and embolization. What about the rest of the study? In my routine, and we have also angiomyolipoma in the liver. In my routine practice, I will change into lung window. Looking for what, my friend? Looking for what? Where are you going?
Cystic fibrosis.
Yes.
Cystic fibrosis. Yes.
No, no,
Cystic fibrosis.
cyst-like lesions, lamb-like, okay?
Yes.
Thin-walled cyst, evenly distributed throughout the lung, okay, without zonal predilection. It's called lamb-like picture, lymphangioliomyomatosis. And also sometimes we can see collection around the kidney. It's lamb lymphangiomas as well. Okay.
Mhm.
And in my routine
Okay.
practice, I will correlate with previous history and definitely previous imaging to assess the presence and or absence of SIGA, tuberous sclerosis in the brain, calcified tubers, periventricular and subcortical and subependymal enhancing astrocytoma and giant cell astrocytoma, and also the degree of hydrocephalus, the integrity of the shunt tube, no collections, no CSF OMA, and also I will correlate with the genetic clinic as well. So we have many
Mhm.
things to be added in the management of this case. This is a long case actually. Okay, and in case of tuberous sclerosis, we have 3 emergencies. In the brain, we have hydrocephalus. If you see hydrocephalus, neurosurgical emergency and shunt tube. In the chest, we have pneumothorax and pneumo and pleural effusion. If you see any, okay, it's emergency for ER or chest radiologist and the insertion of chest tube. In the abdomen, bleeding angiomyolipoma. It's again an vascular or intervention radiology for embolization. Okay, very good, my friend. Not very good.
Thank
You
you,
need to
Doctor.
revise. You need to revise. Okay. Okay, I'll give you one last case. This is the
Okay,
last case
thank you.
of the today. Then I'll talk about the target course, inshallah, the timing. This patient, middle age, no, this one, yes. This patient, middle age and middle age female with loin pain. What do you see?
Okay, presented with a middle-aged female patient. I can see a dense stone at the right lumbar region opposite to
Good,
L4 and
good.
L5.
You said dense what?
A dense calcular density stone, maybe stone.
So it's ureteric stone, but why it's angulated? I think it's better to describe it as oblong-shaped dense structure along the transverse processes, maybe along the presumed site of the ureter. It's okay.
Mhm.
Better than describe it stone, because it's not stone. And
Okay.
what else?
Another dense ovoid shadow seen
Good.
over the right iliac
Excellent.
bone.
Projected over the right iliac bone. Very good. So we have 2 dense structures. One of them may be ureteric, but the other definitely not ureteric. Maybe bony, maybe soft tissue. I don't know. What else?
Okay. Can see my dilated small bowel loops
Good. And
air densities seen at the right renal region.
no, right
Is
renal, usually retroperitoneal. You see the psoas shadow? Psoas shadow is intact. Okay. No, nothing along the right renal. But we have a mass effect, my friend. You see it?
yes. The distended loops are seen displaced
Yes.
laterally to
Very
the
good.
left side.
What comes to your mind?
I'm thinking about ectopic
Middle-aged female.
kidneys or
Okay, let's proceed to city. Let's proceed to city.
genitourinary.
Okay. What do you see in this city?
I
I'll scroll
can
for you,
see
okay?
a hydronephrotic right kidney with delayed excretion.
Very good.
Scrolling.
Very good description, because this is a delayed phase. So this hydronephrotic kidney should show a contrast. So it's a delayed.
Mhm.
What does it mean? Some obstruction.
Obstruction.
Very good. Very good.
Scrolling down, I can see the right If I can see the right kidney, please, the right renal region.
Hey.
Okay, I can see multilocular cystic lesion with
Good.
fatty components.
Yes.
I need to measure the density at the pelvic
Good.
region
Good.
with calcifications.
Yes, it's calcification, not a stone. Good. Good.
Calcifications. I'm thinking about dermoid lesion.
Yes. No solid tissue, no solid
No,
nodularity inside or a large soft tissue component enhancing inside, just a large or a huge multilocular multicystic component containing a fluid and the fat and the calcification. Okay. In this middle-aged patient, most likely right adnexal
dermoid causing hydronephrosis and hydroureter at the right side.
Very good. Management.
I would refer the patient to the urologist and gynecologist after revision of the previous data to evaluate the size of the lesion, the variation in the size of the lesion.
Okay. Any emergency in this case, or this is just to call the case?
I think I could call the urologist emergently to relieve the back pressure.
By? Very good. This is a safety point in this case. The safety point is not regarding the lesion.
Double J stenting.
Wow. The way is obstructed.
Or BCN.
Yes.
But
intervention. Yes. Intervention radiology has a great role in this case. So percutaneous nephrostomy tube may be used as an emergent way to relieve the obstruction, since you see a difference in size and difference in contrast enhancement, a delay in excretion. So we expecting some impairment of the right renal function. So I have to preserve the function of this kidney by relieving the obstruction. Then gynecological referral and to review the surgical excision of this lesion. Okay, my friend? Very good.
The grade of hydronephrosis doesn't affect the decision about nephrostomy tube?
Yes. I think this is moderate to market, but definitely we have some affection of the contrast. A contrast excretion is affected. Some impairment is present. Okay. Very good, my friend. Very good.
Thank you.
Just to revise the last topic today, if you see a perinephric collection, in the exam setting, ask for different phases. Early arterial phase, it may be aneurysm, and even ask for angiographic study if you're suspecting aneurysm or polyarteritis nodosa, fibromuscular dysplasia, rupture. And also remember to assess the aorta. Abdominal aortic aneurysm ruptured in old age. The commonest cause, I think, it will be ruptured angiomyolipoma. Try to assess any presence of tuberous sclerosis, like this shunt tube, lung base in lung window, and so on. And of course, it's all these cases are emergency. If we have a stone at lower calyces, it may be, at lower ureter, it may result into ruptured calyx, ruptured ureter, and urinoma. Another cause of urinoma, it may be something external around the ureter, as in case of aortic inflammatory changes or retroperitoneal fibrosis, or even inside the ureter, not essentially stone, but maybe urothelial tumor. So it may be hematoma, it may be urinoma, it may be just a soft tissue, non-enhancing, or mild to moderate enhancing, as in case of a lymphoma. But of course, no acute history will be mentioned. And in case of hydronephrosis in the exam setting, I don't expect a stone. But something around the ureter, retrocaval ureter, retroperitoneal fibrosis, obstructive lesion inside the ureter or outside the ureter, as in case of dermoid, huge iliac aneurysm, and so on.